So much. You have made a very excellent program for 5 months, and we all are excited.
Yes, yes.
So Naresh
Yes.
and Tirth were telling me
Okay.
very lot of good things about you and the work, the way you work and your team works. So, sir, I'll just introduce Dr. Shyam Shinde. He's the currently he's a very good friend of mine. He's a leading hip arthroscopist based out of Pune, around 140 kilometers from Mumbai. And we have Dr. Raghavendra. He's in Karnataka. So I'll just hand over proceeding to Dr. Naresh to introduce Professor Sushi and Dr. Yoichi. Naresh, please.
Good evening, sir. Good evening, Sandeep sir. Good evening, Sham sir, and especially Professor Soshi sir and Dr. Murata, all the Japanese faculty who joined with us in this webinar as a starting for a HIP webinar series. We are starting on behalf of Indian Arthroscopy Society. I am extremely grateful for the professor for sharing on and accepting our invitation and making a very good schedule for us to learn from the basics of arthroscopy. I would like to introduce Professor Soshi Uchida. Professor Soshi Uchida is a MD PhD. He is the sports medicine head of the department of Wakamatsu Sports Medicine Institute in Japan. His main specialty of interest is sports medicine and joint surgery, mostly in hip arthroscopy. He have got a lot of accolades and a lot of memberships. He is a certified doctor in Japan. He has got a Japan Orthopedic Society specialist, Japan Sports Association certified sports doctor, occupational health consultant. He is a member of AAOS and Japanese Knee Arthroscopy Society. He is a international instructor for hip arthroscopy under ISOCOS, and the institute he made the institute to such a level that it is a ISOCOS trained and ISOCOS accredited center for hip arthroscopy in the world. He has got a lot of awards under his name. To mention some, he has got in 2003 he has got Uehara Life Science Foundation Research Fellowship Award and Canadian Arthritis Network Postdoctoral Fellowship Award. And coming to the academic background, he completed his graduate and postgraduate from Occupational and Industrial Environmental Health Institute in Japan. We have with us Dr. Murata as well, who is a consultant in sports medicine, and he is a next successor of Professor Soshi in the institute, leading the department of sports medicine. Happy to welcome both of them to our webinar. I would like to hand over this meeting to Dr. Shyam Shinde sir to moderate this meeting, as he is the most senior. It would be better, and none would be dealing very good than the mentor than Shyam Shinde sir himself. Thank you, sir. I would like to ask Shyam Shinde sir to take over and start the meeting, sir.
Thank you. Thank you, Gowda sir.
Joining in a while. Yeah.
Hello. I would like to ask Dr. Sushi sir whether he can start a presentation right now. Can you start, sir? You are mute, sir. You are mute.
Yes.
Can you see my slide?
Yes, sir.
Okay, thank you very much for the opportunity to give a talk about history of hip arthroscopy. This is my disclosure. I would like to express my gratitude to our friendship with Dr. Ayapan, who is a first fellow under my supervision in the hip arthroscopy in 2013, and Dr. Ritwik Ganguly, 2016, and Dr. Vijay Kumar, 2022, and Dr. Tirs and Naresh and Pratik in the last years. Thank you very much for coming to the Kyushu to learn hip arthroscopy together. Today's agenda is first, I'm going to talk about history of arthroscopy and also beginning of hip arthroscopy. This is slide shows in the hip history of arthroscopy. Arthroscopy started the Boccini in 1806. The Boccini is a German surgeon, and he first internal RIT device used to inspection the interior of the human body was conducted Dr. Boccini in German, 1806. Just so you know, see here, they didn't have any electricity and gas, so they utilized the candle into the machine. This is also exhibited in the American College of Surgeons in Chicago. Next history is French Dr. Desormeaux utilized the endoscope not only for diagnostic but also therapeutic procedure for the living patient in 1853. He utilized the gas for the light into the machine. And 1877, German Dr. Nitz began his basic work to improve ureteroscopy and develop cystoscopy to extend the bladder. Ureteroscopy is just uterus to see what's going on in the uterus, but they wanted to extend the rest to the bladder. He create device, the cystoscopy set. So this is a model that presents a model is a cystoscopy. This is a northern top to Denmark doctor, 1912. He presented the paper on endoscopic finding with knee using a technique which he named arthroscopy. This is the beginning of arthroscopy. And then Dr. Kenji Takagi is his father of arthroscopy. He examined the cadaver knee with a cystoscope in 1918, and he developed the #1 arthroscopy 3.5 millimeter instrument that would become a model of present day instrument. And Dr. Brutzer in the German doctors, first knee surgeon to use diagnostic arthroscopy. He performed arthroscopy using abdominal laparoscope in 1921. And then 1959, Dr. Masaki Watanabe, he's the father of modern arthroscopy. He developed #21 arthroscopy. And then we're going to talk about the history of hip arthroscopy. Dr. Berman, 1931, Dr. Berman reported the hip arthroscopy for the cadaver, 1931. He get into the joint in the not only hip, but also knee and ankle and shoulder and elbow. And Dr. Kenji Takagi first reported the clinical application of hip arthroscopy for tuberculosis and cervical joints. And the Dr. Berman and the Takagi reported it is very impossible to insert the needle between the femoral head and acetabulum. Since this report, here, 1931, since Takagi, until 1977, the Dr. Gross reported pediatric hip arthroscopy. So about 40 years, 4 decades, no paper and no literature regarding hip arthroscopy. We call dark 4 decades. And then there was a breakthrough from Ericsson traction system. So she utilized a 17-degree scope for the first time. And easy to get into the joint, and for the central fast compartment approaches, and evaluate, able to facilitate to into the joint and inspection to what's going on inside the joint. At the same time, literature from Japanese orthopedic surgeon, Dr. Suzuki, he is also Kitakyushu Kokura Memorial Hospital, and he reported arthroscopic diagnosis of rupture, acetabular labrum, and also labrum diagnosis and management, and partial labrum resection for the successful pain relief. And Dr. Ide reported to perform hip arthroscopy for the patient with osteoarthritis in 1990. And the 1980 to 1990, there are several approaches. Dr. Grigg created a lateral decubitus position for the hip arthroscopy. This is Dr. Grigg. I met him about 10 years ago in Bay, Colorado, in the Bay Hip Symposium. And he was 85 years old at the time. And he also created the technique of reported the decubitus position. And lateral decubitus position was taken over by Dr. Bitter and Dr. Makashi from Boston and Dr. Sampson in the San Francisco UCSF. And Dr. Bird and Dr. Dorfman first reported the peripheral fast approach without traction. Dr. Henry Dorfman is not orthopedic surgeon. He was a rheumatologist. He studied hip arthroscopy from France. And Dr. Dient in German took over his technique. And the peripheral compartment fast technique offers the advantage of limited capsule releases for peripheral compartment exposure and the reduced risk of iatrogenic cartilage and labrum damage during the subsequent central compartment portal placement. And subsequently, Dr. Thomas Bird first reported supine position and modern technique. He evolving instrument and device for the easy to get into the joint. And also evolving of instrument to get access into the joint is Dr. Bird also created with Smith and nephew. And Dr. Philippon first reported the femoral acetabular impingement arthroscopic management. And since 2001, Dr. Gans reported the concept of FAI, and Dr. Guanche and Dr. Philippon and tried to develop arthroscopic technique for FAI. And also in 2009, Dr. Philippon first reported labrum reconstruction if the labrum are salvageable. I went to Bale to learn from Dr. Philippon arthroscopic technique in 2008. And then I have learned a lot from him. And also I devised endoscopic shelf arthroplasty for the patient with hip dysplasia. And the traction system is evolving. And the supine position with peroneal post and lateral decubitus position with peroneal post. And now, 2020, no post supine, Dr. Maza and Dr. Maida is created. This is also next series. We're gonna give a talk about postless approaches. So indication for hip arthroscopy in 1980, only loose body, level pathology, degenerative diseases, synovial diseases, and diabetic arthritis. In 1919, after traction system breakthrough, indication of the expanding and the tumor ectasis and the snapping hip and the painful total hip arthroplasty, instability, and undiagnosed hip pain. But indication after 2000, just the concept of FAI, and indication included femoral acetabular impingement. And indication after 2010, hip arthroscopy and the indication for expanding the extra articular space, trochanteric bursitis, and abductor and adductor repair, and Pili-Holm syndrome, ischiofemoral impingement, proximal hamstrings repair, and fracture, and osteonecrosis, and so on. So in conclusion, this word on, this is the Chinese character, the Japanese character, onko-chishin, we call onko-chishin. This means study the past to understand the present and the future. This phrase refers to gaining new insights to understand while reflecting on the past experience and knowledge. Learning from past experience and knowledge from all the orthopedic surgeons to apply them to address new information systems to consider to a part of experience. I'm going to introduce the next consecutive series of the. This series is also before beginning of hip arthroscopy, and second February, March, and get started to perform the hip arthroscopy, radiography parameter, right patient selection, and complication setup, and also continue to June and July to August, and the extra-articular pathology of the hip arthroscopy. Please stay in tune, and thank you very much for your attention. Daniel Brad.
Thank you, Dr. Ruchida. I would like to ask you one question. Knee arthroscopy and hip arthroscopy started simultaneously. In fact, hip arthroscopy started before the knee arthroscopy. But still, the progress and advancement of knee arthroscopy has went ahead of the markedly went ahead than the hip arthroscopy. How this process you explain? Means what are the reasons why hip arthroscopy not advanced as knee arthroscopy?
It's a great question. Yeah, it's it's the hip joint is the deepest joint in the human body. It's not easy to get into the joint, the first, and then this is the technical demanding, and then every procedure from getting to the access and the evaluation, and it's a steep learning curve.
Yes, true.
And also the patient selection is very important, really important. And if the performed hip arthroscopy for the patient with cartilage damage, severe cartilage damage, and hip arthroscopy is not helpful. That's why it's very you need to experience, or you have to ask experts the hip arthroscopy to this patient is right patient for the indication for hip arthroscopy. So those various kind of factors that the hip arthroscopy is not good progress for compared to the knee and the shoulder arthroscopy.
Yes, thanks a lot. Thanks a lot for your great detailed explanation. But
Our moderator Sundar Rajan sir also joined. Welcome, Sundar Rajan sir.
Thank you, Naresh. Sorry for the delay. I was a bit delayed in that conference. I was held up in the hall today. Sorry, I was late there. My apologies.
Professor Soshi, Dr. Sundar Rajan is head of arthroscopy in Coimbatore, Ganga Hospital, and he was the organizing secretary of IAS Con 2022, and he was a past secretary of the Indian Arthroscopy Society.
Very nice to meet you.
Nice meeting you too. Thank you. Thank you for
He's the one.
thank you for participating.
He's the one who has started this webinars, the series Academic Corner. Is the inventor of that. So, Dr. Sundar, Professor Soshi has just finished his talk about history of hip arthroscopy.
Yeah,
We would like to have your inputs as well.
Yeah, can we go ahead with the second talk and we can discuss?
Perfect.
Okay.
Dr. Murata, over to you. Yes.
Next talk by Dr. Murata. What is FAI? Dr. Murata, please.
Okay. Can you see the slide?
We can see you clearly.
Okay. Thank you so much for giving
And
me
we can hear you as well.
Thank you so much for giving me this valuable opportunity. My name is Yoichi Murata, and under the guidance of Dr. Uchida, now I am working at Wakamatsu Hospital. My specialty is in general hip joints, where I handle hip arthroscopy, osteotomy, and total hip arthroplasty. This time, I will be speaking on the topic, what is FAI? I hope to share information that is beneficial, especially for orthopedic surgeons who are about to start with hip arthroscopy. Firstly, the concept of FAI was first reported by Dr. Gantz in the year 23. FAI is a pathological condition caused by anatomical abnormalities in the hip joint and pelvis, where the proximal femur and pelvis come into abnormal contact due to morphological abnormalities. As a result of this abnormal contact, it can lead to damage to the joint, rib, and cartilage, progressing to degenerative hip joint disease. This diagram illustrates the classification of FAI. It includes the cam region, which is bulging at the head-to-neck junction of femur, and the pincer region, which is a protrusion of the acetabulum limb. Additionally, there is combined type where both cam and pincer regions. This flowchart illustrates the cause of FAI. It is divided into primary and secondary categories. Primary FAI is further differentiated into those caused by sports activity and those related to genetic factors. In the case of secondary FAI, it is categorized into those occurring as a consequence of pediatric condition, such as stripped capital femoral epiphysis or Perthes disease, and those developing as a result of fracture deformity or post-osteotomy complications. I will show you the movies. FAI causes damage to the labrum and cartilage. In cases with pincer lesion, it leads to linear impact, resulting in labral damage. On the other hand, in case with a cam lesion, shear force is applied, causing cartilage delamination. The labrum primarily serves four functions. It is sealing, suction, stabilization, and shock absorber. So it is believed that both FAI and DDH can lead to labral damage, causing hip instability and unstable, and progressing to hip osteoarthritis. In particular, CAM lesions have been reported as a risk factor for osteoarthritis in a 2013 article in Nature. Individuals with CAM lesions are found to be approximately 10 times more likely to develop osteoarthritis compared to those without CAM lesions. Furthermore, it has been reported in 2014 that the risk of developing osteoarthritis is particularly high when the alpha angle exceeds 78 degrees. I will explain when and by what causes a CAM lesion is formed. I will illustrate the prevalence of FAI by sports category. As shown in this diagram, it is evident that the prevalence is high in sports such as football, running, soccer, and basketball. In reports from systematic reviews and meta-analysis on CAM lesions, it has been found that males engaged in contact sports are 1.9 to 8.0 times more likely to develop CAM lesions. Regarding the timing of CAM lesion formation, it has been reported that in both non-power sports and power sports, the alpha angle tends to increase significantly after the age of 19. So, engaging in contact sports leads to the formation of CAM lesions from late adolescence. This is a summary table of the prevalence of asymptomatic FAI. The upper section represents reports from Eastern population, while the lower section represents reports from Japanese populations. It is observed that the prevalence in Western population ranges from 5 to 34%, whereas in Japanese populations, it ranges from 4.2 to 20.3%. Western populations tend to have a higher prevalence compared to Japanese populations. This is the prevalence of FAI among elite athletes. The prevalence is notably high in elite athletes, reaching around 95% for football and NFL players. Even among Japanese professional baseball players, the prevalence is high at 77%. In the diagnosis of FAI, key factor includes the chief complaint, history of present illness, sports history, physical examination, and imaging. This chart indicates the location of chief complaints reported by FAI patients during their initial visit. While pain can manifest in various areas, it is particularly common for patients to complain of pain in the groin or lateral hip. The diagnosis of FAI follows the diagnostic criteria proposed by the Japanese Hip Society for FAI. The indicators for pincer impingement is as follows. C angle is bigger than 40 degrees. C angle bigger than 30 degrees and ARO less than 0 degree. C angle is bigger than 25 degrees and positive crossover sign. The indicators for CAM impingement is as follows. Principal indicator is alpha angle is bigger than 55 degrees. Accessory indicator is head neck offset is less than 8 mm, pistol grip deformity, and hard lesion fit. Two indicators, including the principal indicator, are necessary at least. As you know, Dr. Patrick first described the Patrick test. Other called flexion, abduction, external rotation, Farber test. It is helpful to distinguish hip disorder from spinal disorder. This video demonstrates the performance of the Farber test. the left side represents the healthy side, while the right side represents the affected side. It is evident that the range of motion on the affected side is restricted compared to the healthy side. Thank you for your attention. We are looking forward to seeing you again. Thank you.
Thank you, Dr. Murata.
Thank you.
Very nice explanation of FAI.
Mhm.
I'd like to ask you one question.
Mhm.
Why there are asymptomatic CAM or pincer patients? Means with those patients who have a CAM lesion or pincers, but they are still asymptomatic. Or in a patient where one hip is symptomatic, whereas the radiographic features are the similar on both sides.
Mhm. Thank you for your asking. So that's a good question. So I think asymptomatic athlete have the bone abnormalities. However, so not labral tear or inflammation or cut damage, just only bone abnormalities. The patient who have the symptom is a labral tear or cut damage. It's my thought.
But that's in the same patient where both the hip have the similar morphology, but still he has a symptom on one side.
So that's a good question. I think it depends on the which side is used every day. So for example, the baseball player is right throwing or left throwing or something.
Okay, but I have seen many patients who uses more means for lower limb it is actually equal for both the lower limbs, but in some patients one limb is totally asymptomatic, whereas one limb is very much symptomatic. That doesn't explain get explanation by your this explanation. It doesn't match with this explanation. What is your say on this?
So one more again, sorry.
In similar in a symptomatic patient where one limb is not at all symptomatic, that doesn't mean he doesn't use that limb. He uses both limbs equally. Lower limb we can say about the upper limb he uses is a right hand dominant or left hand dominant using right hand, but in lower limbs are usually used equally.
Equally. So however, so soccer player is he can use the both sides. However, so the prevalence of the side is, I think the football player is the not equal.
Yeah.
I think it's one of the tough questions which you can put on to the faculty because you suppose if you have an osteoarthritis on the both knee, you have a severe arthritis on one knee and less arthritis on the opposite side, but patient has got pain only on the less arthritis side, and patient is completely asymptomatic on more arthritic knee. If you ask the explanation, I think it's very, very difficult to answer. I think it's the same question for him. I think it's difficult to answer.
Yes.
My question to the faculty is what is the incidence of your labral tear along with your pincer lesions, and how do you manage your labral tears with your pincer lesions?
Thank you for asking. So firstly, so we are trying to the labral repair, ankle repair. However, so the pincer lesion sometimes causes we cannot repair the labrum. So in the case of we cannot repair the labrum, we will use reconstruction using the IT bundle, or if the labrum is so small, so we will use augmentation.
Okay. So if you don't augment or if you don't do a reconstruction, what happens? Because usually hip joint is a stable joint. Because the patient problem is basically the pain. If you don't suppose if you are not able to do a reconstruction of the labrum after doing the pincer excision, does the arthritic changes becomes worse if you don't do a labral reconstruction? What is your thought on that?
So one more again.
No, if you don't repair or reconstruct your labrum, suppose if you are not able to reconstruct the labrum after excising the pincer lesion, what is the prognosis for that particular patient? Does the arthritic changes is going to worse if you don't do a labral reconstruction?
Okay, let me answer.
Yeah, please.
It's
Yes,
also a very difficult question.
Yeah.
Yep. The pincer is a global pincer, like a lateral center greater than 45 degrees or global pincer type of impingement. I think labrum is also ossification or it's already gone, and those patients is stable. So I think there is no significant difference between the labrum reconstruction and the debridement. But labrum pincer less than 40, lateral center less than 40 degrees, and not global pincer in a segmental pincer type of impingement. I would recommend labrum reconstruction because there are another substantial parameter to worsen intra-articular pathology. So I would recommend labrum reconstruction. Is that okay for you?
Yeah, that's good. That is a very good explanation, because because sometimes if you are not able to do a reconstruction, if you don't have a facility or if you're not trained what to do, that is a confusion. Because I do a lot of labral repair, but I have not done any labral reconstruction. And another question is that what is your patient's clinical presentation? What is the typical clinical presentation of your hip or your pincer or cam impingement patients? What is in your clinical scenario? How do they present to you with the pincer and the cam lesions? What is the clinical presentation?
I guess 70% is common type, right, Dr. Chera?
He is trying to ask the clinical presentation.
In our series, clinical series, 85% of mixed type of impingement. It's a very similar. Pincer or cam FAI is a very similar symptom. Limited range of motion at flexion and internal rotation of the abduction, and positive Fadia test and the Farber test, and sometimes 50% of the patient have a hip dial test positive test. It's like a labrum significantly, extensive labrum tear that can cause micro instability. So limited range of motion, Fadia test, Farber test positive, and hip dial test positive. If those 4 tests is positive, you have to consider the intra-articular pathology like FAI.
Thank you. Thank you very much.
Can I ask one question to faculty?
Yeah, please.
Is it possible to have a groin pain in a cam or a pincer impingement with the Patrick test or in a FER, in flexion external rotation? Is it possible to have a groin pain? Flexion internal rotation we can understand, but in flexion external rotation with a groin pain, does he have cam, pincer, or mixed impingement?
Yeah, our patient, in the 88% of the FAI patient have a groin pain. 88%.
Yes.
But another patient, 12%, maybe lateral hip pain, and buttock pain, low back pain, and knee pain.
No, in flexion external rotation. I want to.
Yeah.
Okay. So if there are.
Can I ask a question, sir?
Yes, Raghavendra, please.
My question to Dr. Murata and Dr. Uchida as well. So you told us that Dr. Murata told in his presentation that pincer is more prevalent in Japan population, isn't it? That's what he showed in one of the slide than CAM, because we also have same patients in Indian population where there is a global overcoverage of a femoral head due to coxa profunda or deep socket related issues. And it's not that we don't have mixed type of FIA in our Indian population. We do have radiological, morphological FIA, but they're not symptomatic. The symptomatic patients who comes to us are more of a pincer related, especially the elderly females plus 45, plus 50. Is it the same situation in Japan as well? Or do you have this classical mixed type of FI patients in your Japanese population?
I think it's a similar population. Yeah.
Yeah. You mean to say it's more of pincer?
But CAM is more prevalent than
More
pincer.
prevalent. Okay.
Yeah, more prevalent. CAM is more prevalent.
Okay. And I have one more question for you, sir. In isolated pincer, as long as the chondrolateral junction is intact, so it is a usual situation there where whenever we have an isolated pincer lesion, especially like in a deep socket or coxa profunda, or isolated, focal overcoverage of femoral head due to acetabular retroversion. So you still in those cases have any labral pathologies when you have isolated pincer? No CAM, only isolated pincer.
So those you're asking the pincer type FAI have what type of specific?
Yeah, I'm asking you how often you find this labral pathologies in, and how often you do labral repairs or augmentation or reconstruction in isolated pincer type of impingement.
Pincer type impingement have a various type of labrum pathology. Mostly the labrum ossification, and very labrum is hyperplastic. There's so much linear impact.
Yeah.
The labrum it's gonna be, it's fragile and it's gone, and maybe 1 to 2 millimeter width of the labrum.
Right.
And also flattened labrum, and also growing pincer limb is go up to the labrum. It's separated from the normal cartilage. Those patients, it's very difficult to repair the labrum. So that's in those cases, we take down to the labrum. So try to preserve as much as possible, and then resect the pincer lesion until the normal cartilage, and then try to put it back to the labrum. But I think it's very in unsalvageable labrum. In those cases, and we are doing labrum reconstruction. Reconstruction with repair, we call augmentation.
Okay.
Yeah.
Right. Okay. Thank you, sir.
Thank you, Raghavendra. Can you start your talk? Thank you for answering all the questions. Thank you, Amish.
Go ahead.
Can you see my slide, sir?
Yes, we can see you.
Right. Okay. Thank you so much, IAS, once again for giving me this platform to present a case report. It's always an honor and privilege to present in any IAS platform. Thank you, Dr. Naresh, for the invite. And I also like to thank Dr. Uchida and Dr. Murata for their guest talks. It's always an honor and privilege to learn from the experts of world fame. Thank you so much. So my name is Dr. Raghavendra Kimbavi. I work in KVC Super Specialty Hospital, Mysore. And I'll be talking case report which I operated around 6 weeks back. It was a hip dislocation, posterior hip dislocation with femoral head fracture, Pipkin's type 1. Sorry. Okay. So basically, my patient was around 26-year-old ambulance driver. It was a severe road traffic accident, head-on collision. He presented to us immediately within 3 hours with a flexion, adduction, internal rotation of right lower limb, and he also had a swelling of a right knee with the posterior drawer test positive. He had a deformity of a left leg on the left side, which was type 1 compound, and vitals were stable, and there were no visceral injuries or head injuries or any other injuries. So this was the imaging. So he had basically posterior dislocation of hip along with a small superolateral acetabular rim fracture, and he had a Pipkin's type 1 infrafoveal head femur fractures. These were the CT images, and this is the video. So the associated injuries on the same side, he had a right posterior cruciate ligament complete tear, and he had a patellar tendon avulsion fracture on the inferior pole of patella, and on the other side he had a type 1 both bone fractures on the left side. So my diagnosis on clinico-radiological basis was posterior hip dislocation with femoral head fractures, Pipkin's type 1 infrafoveal, and the same side on the right side he had a PCL posterior cruciate ligament complete tear with a patellar tendon avulsion on the patella side, and on the opposite side he had a both bone leg fracture type 2 compound, and there were no distal neurovascular deficits. So my plan was to go ahead with close reduction first for right hip, and once I achieved the close reduction, my plan was to fix the infrafoveal fragment of the femoral head arthroscopically. I also, in fact, I would have done that this arthroscopic procedure next morning, because he came late in the evening. But due to financial constraints, I was forced to do both the surgeries at one go. And he also, I did after that I did the patellar tendon avulsion fixation and intramedullary nailing for the left leg. So the challenges here for hip arthroscopy was to achieve do a proper gentle reduction, because I did not want to displace the fracture fragment of femoral head, because many times it might get incarcerated between acetabular margin and femoral head, causing difficult reduction. So in such cases, we have to open. So that is the last thing I wanted to do, because doing arthroscopically was in my mind always. So gentle reduction was the key, and stability after the reduction. That was very important for me, because I have to do over the year from last year I shifted to peripheral compartment first. I began my hip arthroscopy with outside in capsulotomy procedures, but over the years I shifted to PC first. So for that I need to have 30 to 45 degree of flexion at least to begin with. So my worry was whether it's stable after a close reduction or not in hip flexion. So fortunately, it was a stable hip reduction even in 90 degree. So once I reduced the hip, so I went ahead and did the arthroscopic fixation of the femoral head. Supporters, just like we do for any other PC first or peripheral compartment first technique. So 4 portals basically proximal anterolateral portal, anterior portal, anterolateral portal. Sorry, that's DALA, distal anterolateral portal, and anterolateral portal. So proximal anterolateral portal, anterior portal, and DALA are used for fracture assistance and management. The anterolateral portal, I use it for basically visualizing the central compartment. So it essentially forms a shape of a diamond. So to begin with, so injecting a saline from proximal anterolateral portal, PAL, which is a line forming between ASIS to tip of a greater trochanter, medial 1/3 and lateral 1/3, lateral 2/3. So same sequence, passing a nitinol guide wire, and after that passing a cannulated trocar system. So once we pass the nitinol guide wire, we can feel the resistance of the medial capsule. That means we are inside the joint. So then go ahead and pass a scope. So first thing is to a diagnostic scoping. So this is a medial synovial fold, just like any other peripheral compartment first. Medial synovial fold, assess the capsular zona orbicularis, so minimal amount of head fraying here on the anterior inferior quadrant, and that's a fracture site. And visualizing from the lateral side, so that's a labrum, paralabral sulcus, and the head, and that's a fracture site. I didn't find any rent in the capsule here. Or maybe the rent or the capsular tear was posterior to lateral synovial fold. And I did try to visualize pulsation of medial circumflex vessels just lateral to just posterior to lateral synovial fold, but here I didn't find any pulsation. Probably it was in the spasm status. So next thing is to do capsular thinning arthroscopically. The first instrument portal site, anterior portal. So use a shaver and do a capsular thinning just to increase the working space and maneuverability between the femoral head and the capsule. So then go ahead and clean up the fracture sites, take out all the blood clots, freshen up, not removing much of a bone because it's already a thin fragment. So next thing is to go ahead, just like we do for any other fractures, use a cannulated system, use a guide wire first. So the first screw I passed was from the anterior portal. So after passing the guide wire, provisionally fixing with the guide wire, I passed the cannulated drill and passing a screw of Herbert screw of 3 mm. The first screw I used was around 35 mm. The very important aspect here is to have a good compression. The fracture was not displaced. That fortunately it was not displaced. It was only opened up. So my only job was to compress the fracture as much as possible with a couple of screws. And here in this step, this hub pipe really came handy because I had to compress the fracture with some blunt instruments. So hub pipe was really useful in this step. So posterior to this screw with the guide wire, I used a hub pipe to compress the fracture. So that was the first screw. Second screw, same step, but the portal was different. I used DALA portal. Same, pass a cannulated, pass a guide wire, then cannulated drill bit, and pass a second screw from the DALA portal of size 30 mm. So as we can see, the fracture has already been compressed. And there is some amount of cartilage fraying here in the anterior inferior quadrant of the femoral head. And I don't think that should be a problem because it's unloading part of the femoral head. So that should not be a concern. probably. So finishing with the second screw and achieving a good reduction. So then going ahead, after once I've fixed with a couple of cannulate, a couple of Herbert screw of size 3 mm, visualizing the central compartment, and fortunately I didn't find any labral pathology here except for a few blood clots, and controllable junction was perfectly fine, and there was no labral tear. Even the articular, even the loaded part of the femoral cartilage was completely fine. So this is the post-op images, intraoperative images with a screw in situ and fracture being compressed well. So these were the intraop X-rays, AP and done 45-degree lateral. As we can see, the fracture is reduced well. And this is 6 weeks post-op. So joint is congruent except for small supralateral rim fracture of acetabulum, and XL looks good. Post-op protocol, since I am to do a PCL on the same side, I have not started him weight bear as of now. But in-bed mobilization was started at 3 weeks with hip ROM, and probably once I do a PCL, I'll make him weight bear. Discussion. So very essence of these femoral head fractures are they are very rare fractures and commonly associated with posterior hip dislocation. Around 6 to 15% of posterior hip dislocations have this femoral head fractures. And there are numerous classifications, Youn's classification, AO, Chiron's, Rumbach, and none of the classifications are perfect. Every classification have their pros and cons, but most commonly used is Pipkin's, and I think many peoples are managed according to Pipkin's classifications. So here is a Pipkin's classification: type 1, 2, 3, 4. Type 1 is infrafoveal, type 2 is suprafoveal, and this is very important because suprafoveal is most fractures involving the most of the weight-bearing area of femoral head. So we have to fix it at any cost without any fracture incongruity. And type 3 is type 1 or type 2 femoral head fractures with femoral neck fractures. Type 4 is again suprafoveal or infrafoveal femoral head fractures associated with acetabular fractures. Now, what is the mechanism of such injuries? We know dashboard is a common entity for any posterior hip dislocation, but whether it's suprafoveal or infrafoveal, that depends on the limb position at the time of trauma. So for example, in hip flexion plus with the force reduction, then it's a pure hip dislocation with resulting in a small osteochondral fragments. With the hip flexion and intermediate adduction, it results in a posterior hip dislocation with infrafoveal femoral head fractures. And third one, hip flexion with the neutral adduction, that will results in posterior hip dislocation with the suprafoveal femoral head fractures. And in my case, probably it was hip flexion with intermediate adduction. And we have to know that there will be no femoral head fractures whenever there is abduction at the time of impact. So it is usually acetabular fractures or central fracture dislocations in such cases. So management, there is no proper consensus, probably which shows that rarity of the fractures. So we don't have any proper consensus when to do what. So whether we have to go for conservative management or operative management, and when we operate, whether open is better or arthroscopic management of femoral head fracture fixation is better, or when we do some kind of surgery, whether fixation is better or excision of femoral head fracture is better. But with whatever literature we have, these are the general guidelines. That means that whenever we have a joint incongruity or hip instability, or whenever the fracture fragments are more than 1 mm, or whenever there is intra-articular loose bodies or loose fragments, we always have to go for operative management. If not, if these points are satisfied, then we can go for a conservative management. The traction of 4 to 6 weeks. So open or arthroscopic fixation of femoral head fractures, as I mentioned, there is no literature which says that no, open is better or arthroscopic is better. But this is a paper in 2023 by from China, and they made a few guidelines. All these procedures were open procedures, and they made general guidelines regarding Pipkins 1 and 2. Conservative management, they did conserve for a lot of femoral fractures with the same guidelines which was mentioned before in the previous slides. Type 1 fractures, they operated in 72% of the patients, and the incidence was slightly high on Pipkins type 2. That's probably because of in 80% of the patient they did surgery, probably because of suprafoveal involvement. That's weight-bearing area of femoral head. So whenever they did open procedures, Smith-Patterson approach, anterior approach was the best approach for such fractures in Pipkin 1 and 2. But however, having said this, whatever modality of treatment we use, whether it's conservative or surgical, the best prognostic factors of such fractures are early diagnosis and prompt anatomical reduction. Now, whether we need to excise or fix the femoral fractures, there was a paper in 2013 again. Probably this is the only largest of the series where they have managed femoral head fracture arthroscopically. They have done around 15 cases, and they clearly said they came up with the guidelines saying that whenever we have a type 2 Pipkins, always fix. There is no question of excision because it involves weight-bearing area of femoral head, so always fix it. And whenever we have a type 1 infrafoveal Pipkins, if fragment is large enough, if more than, for example, more than 2 centimeter, fix it. And if it is smaller fragment, less than 2 centimeter or comminuted, we can go for excision. And surprisingly, whenever they did excision in type 1 Pipkins, the excision group had a better outcomes than fixation groups. So arthroscopic femoral head fracture fixation, as I mentioned, not many studies which have done, which are published in the literature. There are only so far 5 case reports and 1 case series, which I mentioned previously. And most of the studies were done in Pipkins 1 and Pipkins 2, and they used the same Herbert screw all the studies, either 3 mm or 4.7 mm. And most of the portals through which they fixed fracture was DALA, distal anterolateral portal. And one case report they fixed from the posterolateral portal. And again, it depends on the fracture configuration and shape. So we have to use the proper portals to fix the fractures. And this case series, again, around 13 patients, they fixed it. 8 cases, they excised femoral head fractures, and both were again type 1, type 2. And for fixation, they used Herbert screw of 2 mm, and they were not clearly mentioned which portal they used. Probably they used the same DALA portal, and post-op protocol for them was immediate to touch weight bearing. So complication, I'll be telling only regarding the in acute traumatic condition scenarios. I'll not talk about the general complication of hip arthroscopy. In acute scenario, probably these are the issues we can come across. increased risk of abdominal compartment syndrome, retroperitoneal fluid extravasation, and the traction time. There can be pre-existent some neuropraxia of a nerve, like a sciatic nerve. So we have to be very careful whenever we are using a lot of traction time, because it can add up our neurological injury as well. And pulmonary embolism can be a quite devastating problem, and it's absolutely contraindicated in hemodynamic unstable patients. Now, this is my view, which portal we have to use in such acute scenario conditions. And I feel it's not been told anywhere, but I feel that PC first, peripheral compartment first will be the better entry technique in such acute conditions. Probably because we can address the fracture first and then go into the without traction, and then we can go to the central compartment with traction. So basically, we can reduce the traction time with a peripheral compartment first technique. Outside encapsulated technique, I think the preference should be less, because as we are doing large obligatory capsulotomy, there will be fluid extravasation leading to this kind of abdominal compartment syndromes. This is my view, but probably at the end of my talk, we can have expert opinion. Pitfalls, again, traction is an issue. It can displace the fracture, and it can also cause vascular damage to the femoral head, adduct. And screw length estimation is a real problem in fixing such fractures. So misreading can be a problem, which can lead to a poor fixation or intra-articular protrusion of the screws. To conclude, I think the proper planning with CT is must. Early diagnosis and prompt reduction are the better prognostic factors to prevent long-term complications. Hip arthroscopy allows the direct vision and the reduction of a fracture fragment. Portals are important. We have to have a proper portals, and screw length again to have a good reduction or to avoid the intra-articular protrusion of the screw. And of course, it's a long learning process curve. It's always better to do hip arthroscopy for other conditions to begin with, like synovitis or diagnostic or FII, than jumping into the acute traumatic setting first. Thank you.
Thank you, Raghavendra, for the excellent case. Because I don't have a personal experience of fixing the fractures through the hip arthroscopy. Anyway, I don't do trauma nowadays. Maybe ask the opinion of our professors from Japan, so they can give an expert comment.
Thank you for the presentation. So nice. I think so. Very good surgery. So if I perform the surgery, I will use absorbable pins for fixation.
Sorry?
Absorbable pin.
Oh, okay.
Observable screw.
Oh,
yeah.
Okay. Nice, right.
Raghavendra, do you have any concern, as you said, the complications operating on this next day itself by arthroscopy, because you read about the extravasation of the fluid or compartment syndrome? Was a concern?
Not exactly, sir, because vitals were stable, and I didn't find any per abdominal problems when I examined the patient. There was no abdominal tenderness, and it was purely isolated to hip. And and after reduction, I got a good stable hip, and I thought, why not to go ahead with and fix the fracture rather than wait for next morning.
But because like when you have a PCL avulsion, when you do a arthroscopic fixation,
Yes.
generally we wait for at least 1 week to 2 days so that it allows the capsule to heal and prevent the extravasation of the fluid and preventing the complications like a compartment syndrome.
Yeah.
Even the hip fracture also can wait for 1 or 2 weeks. It doesn't matter, isn't it? So that's why my question. Okay.
It's true that fluid extravasation is a major challenge in such cases, because that patient was also a polytrauma case. There were more than one fractures. There might be pelvic injuries as well with these fractures, with the muscles of the pelvis. So fluid extravasation is very challenge. I have faced one case and with catastrophic outcome.
Any other questions?
Sir, I have got a question for Ravindra sir. Sir, did you face any problem while placing the traction for the case? As there is one side there is a patella fracture, sorry,
No, no.
tibia fracture.
No. I didn't have any problem with giving traction.
So how did you handle? Can you please tell?
Yeah, the key is to not to give over traction. Just enough, because this is a fresh case, so distraction of the hip joint should not be a problem here. Unlike the if the patient would have had a pre-existing conditions like any adhesive capsulitis or diabetes or FIIs, pre-existing hip pains or any other causes, I think then in that cases the distraction would have been difficult. But this is a fresh scenario, fresh case, trauma. So once I fixed a fracture, I just needed the manual traction to open up the joint. Traction was not an issue here.
Okay.
Okay, if there is no further questions, Naresh, do you have any questions in the chat box? Or?
Sir, there are no questions in the chat box, sir.
Okay, I would thank professors from the Japan and Raghavendra for their excellent presentations. It was very wonderful. I hope that our listeners might have gained a lot of experience by getting knowledge from these experienced surgeons. And you can go for your closing remarks, Naresh and Sandeep.
Thank you very much, sir. So I would like to thank Dr. Uchida and Dr. Murata for their excellent beginners talk in this webinar about the hip arthroscopy history and the femorocervical impingement, and Dr. Raghavendra about the very well presented case about the Pipkin's fracture. So I'm sure it was a very informative session today, and very thankful to our both the moderators, Dr. Sundar Rajan, who is from Coimbatore and currently in Pune, and Dr. Shyam Shinde for moderating the session, because Shyam Shinde sir also has got a conference. I'll be meeting him tomorrow, and he himself is organizing secretary, but he still spared time for our webinar. Thank you so much, and thank you all the viewers and the team from the Japan, Dr. Naresh, Tirth, and everyone who joined on Zoom platform. Thank you.